Miss you. Well, we're back, so. Delete forever. All right, can you all hear me? I'm gonna skim through this and just make sure that there isn't anything else. Seems fine, seems fine, seems fine. I apologize for my ignorance of this guy. Yeah, I mean, it is what it is. Okay, so here's what we can do. Because it looks like, pop out for YouTube. Fuck. All right, let's see. That should be good. Sorry, I'm just double checking and make sure. If other people would like to help me, and just go and make sure that everything is cool, we're just going to listen for a bit. We're just going to listen to it off screen. All right. Just to be safe, because again, I don't want to violate TOS. I don't want to do anything that goes against the rules. Just trying to do everything kosher. All right, we're just trying to learn. All right, what happened to the vid? We're just gonna listen to it. Off screen. So here.
They don't have the testosterone to make it grow. So there's a very famous transgender girl named Jazz Jennings who went through her whole surgery thing and outlined the biggest complication she had was her vagina was about
unfortunately, to show it would be TOS.
And it was because Jazz had never been allowed to go through regular puberty, which means that she had more or less been a toddler penis. It never grew any, and that's what they were able to use to make the tissue to do the neovagina. So as funny as it is to say, about 6 months before any of my patients go for gender-affirming surgery, I start slathering them up with 0.5% testosterone every day. This will make the biggest, strongest penis possible to go into battle that you're going to use to turn into a neovagina. This is very important to do this because they've often spent 4, 5, 10 years on blockers and have experienced significant genital atrophy as a result. The same can also happen in reverse to transgender men, but not as often. Testosterone seems to be a little friendlier to the vagina, whereas estrogen is a thing that just does not work on trans women's penises. Like, don't even bother. Estrace will not work to help them with this issue. Same idea with male to female. Lupron is used to do the blockade.
All right, there we go.
Lupron is used to do the blockade. There is a tremendous discussion and argument over what is the best way of doing hormones. It's mine.
All right, this should be fine now. For at least as long as we're going to
be It's not really a thing that has been settled on anybody yet, so I'll present you mine.
Can you all
and the
see
other
me
options
fine now?
You guys can decide for yourselves. Male to female, I mean, you get feminization, breast development, adipose redistribution, testicular atrophy, possible infertility. So infertility is a thing that people talk about a lot, and I actually have not experienced it that much with my patients. So when I have a transgender woman who decides that they want to father children and they still have not had an orchiectomy and they would like to produce sperm, I stop their blockers, I stop their estrogen, I stop everything, and I put them on a drug called Clomid. Clomid is also used for fertility purposes in women, clomiphene, but it increases the LH and FSH secretion from the pituitary, which thereby kind of restores the testicles. And they can go from these atrophied little wimpy, squishy grapes to being like solid, hard, large marbles within the span of about 2 to 3 months. Then they can give themselves a sperm donor, or they can do whatever they need to do to drop their sample or impregnate their partner, and then go right back to how they were before. And I have done this a bunch. So I've actually not had a patient that was infertile that I couldn't fix, except for the ones that had an orchiectomy. And there's nothing I can do about that. Once you've had that, that's pretty much the end of the game. Anyways, so same sort of things in reverse. This is an interesting slide. So when I start people out, I start them between 6 and 10 milligrams a day, spread over the course of the day. Ideally, I would love to have them dose it 5 times a day, but few people are that compliant. So I usually am happy with 3, like 4 milligrams in the morning, 2 in the afternoon, 4 at night. Almost every other doctor will tell you, take all your pills at once, it doesn't matter. That's wrong, and here's why. When you spread the dose over the course of the day, they don't crash. These people who are dosing 10 milligrams of estrogen first thing in the morning, 12 hours later, they've half-lifed out 3 times. They feel like shit, and they always wonder, I'm so tired in the evening. Well, yeah, because you have hormones only part of the day, and that is absolutely not how an ovary works. It's not like an ovary wakes up at 8 a.m. and like has its morning coffee, squirts out some estrogen, and then goes to sleep for the remainder of the day. It doesn't work like that. So why would we do this to humans? I don't know, but I don't. What I discovered that's a really large portion of my treatment is this thing called estrone and estradiole's ratio. Estrone is a metabolite of estradiol, and it's also a thing that's produced from androstenedione. It is about 4% as strong as regular estrogen, regular estradiol, should I say, and it is a competitive agonist for the binding site. I have found some transgender women have a mutation where their body will take estradiol and convert it into estrone. Lots of it, to the point where it's 20, 30 times greater amount of estrone than estradiol. I think this may be actually related to the development of their gender dysphoria, and we're going to talk about it. Now, earlier you saw this slide, and on that slide, this arrow went like this, just down. That is wrong. And it has historically been taught that way, and it is wrong. And specifically, the reason it's wrong is there's 2 enzymes there, 17-beta oxidoreductase and hydroxylase, which are involved in the processing of those 2 hormones. It goes in reverse. It is reversible. And I have found increased or mutations of increased function going one direction or decreased in the other direction, which screws up this ratio. So, what does it matter? Well, let's say that you have a patient, and we're going to just follow the WPATH standard here really quick. Not my methods, we're going to say the WPATH. So, estradiol, you get it back, it's 100. To me, that's too low. I like it over 300. But WPATH likes them 100 to 200, so they say that's okay. Great, all right, everything's fine, keep transitioning, have a good day. I get your estrone back, and while your estradiol is 100, this is 500. Most cis women are really around 100, never over 200 ever. Their physiologic range never goes that high. So, what's up with that? Oh, I better lower your estrogen. Yeah, your dose is not enough. Here, you don't have enough estrogen. I need to increase it to get you closer to 200. Oh, nope, you have too much. I have to decrease your dose. Oh, nope, here's your total estrogen. This is pretty much peak ovulatory levels. This is fine. Depending on which lab you ordered and how you looked at this patient, you would come to the wrong conclusion. Which is why my whole point is estrone is a key component that you need to measure when you're looking at this. Estrone also is important to measure in any of your women that have had breast cancer or a thrombotic event, because it is implicated in the development of both. So, as we talked about here, the effective estradiol level in this patient is much lower than 100 picograms per milliliter. So let's imagine this. All right, so we got these chairs over here, okay? These are estrogen receptors. So let's say we have 10 guys up here wearing estrogen shirts, and they're like, I'm estradiol, 10 of them. And then I have 50 wearing estrone shirts, and we play musical chairs. What assortment of people are you going to get in there? I mean, obviously, 5 out of 6 chairs are going to be occupied by the people wearing the estrone shirts, because there's way more of it. But they both bind to the receptor. It's just that when the estrone binds, it only gives 4% of the effect. Subsequently, the irony of this is that giving transgender women who have this mutation.
This video is around version 4.0 of his ideas, I think. He's since moved on from a number of the conclusions / reasonings he drew here, admittedly being a bit ahead of himself. Interesting. If you could send me like updates on where he's at right now, that'd be really useful, or that would be useful. Thank you.
Estradiol creates an enormous amount of estrone in their liver, which then competes with the estradiol for the receptor binding site. So they start transitioning and then stop because they get the initial feminization burst from estrogens effectively, and then they can never get past that. They just get stuck. And the reason I dreamed this up is I'm like, why do people keep saying this, shots are better, I couldn't transition until I went to shots. I'm like, what would the difference be between oral and shots? Like, I don't get it. And I started looking into the biochemistry of this until I finally dreamed this up with Sigrid, who I quoted at the beginning of the lecture, who I gave credit to. Brilliant woman. But anyways, the relative speed of the enzyme, the 17-beta-hydroxysteroid oxidoreductase and hydroxysteroid dehydrogenase, is interchangeable. So depending on where your mutations are, how many allelic polymorphisms you have in either direction, you're going to either go towards this end of the reaction or the other end. And this is important for transitioning. What's really weird is that I have found elevated estrone levels in transgender women who later went on to have screwed up ratios in this problem before they started transitioning. Meaning their body was taking, when they had non-elevated levels of total estrogen. Their total estrogen is like borderline high or normal, but their estrone is high because they're shunting into this. Now, I think that this is particularly interesting because I have previously been like, estrone's bad, no, terrible estrone. I've been doing that for years once I discovered this. What I recently figured out was that the patients that I started on pills that I switched to shots ended up having better feminization and larger end-stage breasts than the patients I started on shots. And I couldn't figure out why that was. And so I started to think about it, and when we talk about thelarchy, which is the development of breasts before menarche, thelarchy is the development of the breast bud and then its initial formation. That comes from the adrenal glands primarily, from estrone being released in the adrenals. After that happens, eventually there is an inversion when the ovaries kick on, and then you start to progress to Tanner 3, Tanner 4, then you start cycling and you having a period, and then you progress to Tanner 5 and the breasts round out. So I realized, maybe this would be better. So I actually let my patients stay on oral pills even if they have a crappy ratio for 6 to 12 months, then I switch them. Because effectively I'm mimicking thelarchy in a cis girl who would go through the same sort of thing. What's really interesting, and I have yet to totally suss out the mechanism for this, I've had patients that have been on shots for an extremely long time frame, like 3, 4, 5 years, where they are considered done. This is as far as they're going to progress, no more further feminization. And I added an oral dose of 2 milligrams at bedtime, swallowed, not sublingual, not buccal, swallowed, deliberately creating estrone. And all of a sudden they start progressing again. Despite the fact that their estrone level goes up against this ratio. It almost seemed contrary to my theory, but I believe the mechanism for this is that the estrone is actually uptaken into the cell and converted to a different form called E1S, estrone 1 sulfatase, or sulfate. The sulfatase enzyme is the thing that does it. And that form, E1S, hangs out and does nothing. It's sulfated, it just chills. But it can be pulled immediately and then converted to estradiol intracellularly. Now, the serum drifting around estradiol around your body, yeah, that's great that you have that and you have a high level, but it doesn't do anything unless it's inside the cell. This is picked up easier and taken into the cell. So it acts as a reservoir for E1S, and in these patients who've been on shots a really long time, who might have a depleted estrone reservoir, it seems to re-trigger growth in them. So what I do now is when somebody's maxed out, like totally maxed out, I give them this oral dose for a month. And if they start progressing again, they start getting more breast development, I have a phrase that I say all the time, which is sore boob is more boob. If they're sore, they're growing. That's a general marker for it. If they develop tenderness again, then we continue with this. If they don't, I don't do it past a month. All right, so as I talked about, I start them all that way. If the ratio is poor, I switch them to injectable. If the ratio is good, they can be maintained that way. I'd say, even since I would say about half now. I really should update this. I used to say about a third to a quarter, but I'd say about half of them have this genetic issue where they just cannot process it properly. There are the options for transdermal estrogen and implants. I rarely use these, mostly because I can never seem to get as high of a level as I would like, but I have a couple patients who have the mutation with the estrone issue, and they are just terrified of needles. They just won't use them. They're just like, no shots. And I'm like, okay, well, you're stuck how you are, or this. And the option is either transdermal gel or usually 2 to 3 max dose patches simultaneously. There is also estrogen implants, but they're not approved in the US through any sort of like FDA okayed drug, like Testopel is the testosterone one. There isn't an estrogen one. But you can get it compounded at a compounding pharmacy and then do the same thing. It does exist in Europe. So this is what I think is going on here, and this is just a theory, so you can take it with a grain of salt, but I believe that this is actually the cause of why a lot of these people turn out to be transgender women. So if you have this mutation, which I said about half of my patients do, where they crank out this massive estrone level, so when I say that, to be clear, they'll have an estradiol of 100, 150, and I'll measure their estrone. Someone broke the record the other day by having an estradiol of 100 and an estrone of 38.27. Normal estrone is 100 to 200. So that gives you a concept of like how bad the mutation was in them.
Sorry.
What they are effectively doing is I'm giving them estrogen. Their liver is like, cool, estrone, pile,
It's very coffee right now.
pile. And it just starts stacking up more and more and more. Well, if you think about it, what is the other time that a male fetus, besides being a transgender woman, would be exposed to estrogen?
It's going to turn out I have
Pregnancy.
the
So
Rona.
in pregnancy, you are exposed to mom's
no.
estradiol. I eliminated my mom's. I just went,
I say
nope,
that
and got rid of
seriously,
it
like, actually,
because
it's
I don't need
mildly
it, and
concerning
my
that
body
I'm
produced
thinking
its own androgens, which is why I turned out with my SRY gene expression to be a boy. I am a boy, if
Bleh.
you hadn't known. I do also identify as one. But if you have this mutation, you're going to take mom's estrogen, and you're going to crank it into estrone. Now, mind you, estrone isn't a super powerful estrogen, but we already know it's enough to at least give people breasts. So if you're exposed to this throughout your entire development period by taking mom's estradiol, converting it to estrone, and building up this reservoir inside your fetal body, what do you think is going to happen to your neural architecture? Well, I don't know. It's not like we don't have a comparative analysis in DES, which shows us exactly what happens when we expose a developing fetus to high levels of estrogens. So this is why I think at least some transgender women who have this mutation are trans because of this mutation. And the sick irony of it is that later in life, when they go to try and actually transition, you put the hormones back in, it makes it harder because their body actually fights them by converting the estradiol I'm using to estrone. So this is an example of a patient just like what I was talking about. I really should use my new patient, the one I just got the crazy labs on the other day, because it's even more pronounced than this one. But basically, this patient had an estradiol of 78 and an estrone of 2100 when I checked it. They were told that this is as far as they could go. They've been on hormones for like 10 years. And that was it. They were kind of happy with how far they had progressed with their transition. But their prior doctor had only been checking the estradiol level. They ranged anywhere from like 80 to 200, and everything was fine. 4 months after I correct their ratio, I saw them as a patient. I'm like, hey, listen, you have this thing. Let me fix this for you. And they were like, very suspicious, because when someone's been doing the same thing for 10 years, it's hard to convince them to change. But they did. They listened to me, and holy crap, did they change. We're talking they went from like a small B to a D by the end of the year. Within 4 months, it was blatantly obvious that I had done something very different with this patient. They were thrilled because they had thought that they had gone as far as they could go. And it was because they had this mutation. I have seen this, which I'm trying to figure out right now. Norvir and cobicistat in my African-American transgender women are 57% HIV positive. I'll repeat that. 57% of my African-American trans women are positive already. That's real. White is about 7 to 12% depending on the state. So in short, a lot of them I have on HIV treatment. I also treat HIV, it's the thing I do in my clinic. And a lot of the older / middle, and not the brand newest drugs, but the ones from maybe the past 5 years to 10 years ago, use this, cobicistat. It's a booster. It basically inhibits the cytochrome P450 enzyme, keeping the level of the drug higher in the serum. Norvir did the same thing. And they screw with estrogen metabolism. So it also makes this problem even worse. So I would recommend if you have a transgender woman you're fixing this problem on, and they're on one of these drugs, consider one that is an unboosted regimen. I'm not the first person to discover this. It's kind of crazy. This has been known in medical literature for literally almost 15 years. 2005, varied routes of administration affects the way that estrogen metabolism is done. Right here, you can see this was the study. Estrone is a weak estrogen, only 4% of the estrogenic activity of estradiol. I'm not the first guy to dream this up. I already talked about that. However, we've known that it's bad. We know this. Association with estrogen receptor positive breast cancer, relationship between estrogen and estrogen metabolites, the postmenopausal breast cancer risk. This doesn't say here, but I'll tell you the abstract, the conclusion is estrone's bad, causes cancer. Estrone sulfate promotes human breast cancer cell replication. The effect of estrone on thrombin generation may explain the different thrombotic risk between oral and transdermal hormone replacement therapy. So I only use, in my practice, bioidentical hormones. That's it. If you come in and ask for something else, I say nope. And in 1,500 patients in 5 years, I have had 0 complications. Not a single DVT, pulmonary embolism, nothing, not even one. And I use doses way higher than what the WPATH says is safe. Statistically, I should have had like 5, but I've had 0. And I think this is the reason, is that I only use bioidenticals and I pay attention to this. Estrone generates thrombin. So if we're giving people oral estradiol and they have this mutation and all of a sudden they have an astronomical amount of thrombin in their blood, what do you expect? All right, let's talk about blockers. So sometimes it's necessary to use blockers. The testosterone sometimes will just go down on its own when you give somebody estrogen or progesterone, but sometimes you really got to beat it. As a result, you use blockers. And the historical way of doing this is stuff like finasteride and spironolactone, which I despise, and I'm going to talk to you about why. But the crux of what I do is to use bioidentical hormones, and on very rare occasion, an androgen receptor inhibitor called bicalutamide to do this job. So I don't prescribe Spiro. If you come to me on Spiro, I will take you off of it. I will not write it. It is the standard of care according to every major medical group everywhere except for me.
Also, hey, welcome to all the new people.
I'm going to let you know they're going to tell you to write Spiro. Why we think a potassium-sparing diuretic that causes, and this is known, depression, fatigue, visceral adiposity, like it increases serum cortisol levels, which is probably the reason why people get visceral adiposity. We know that it has issues with breast development. So this was a really cool study that took every single transgender woman from like Europe and this whole distribution, like thousands of people. And they looked at what they had used in terms of hormones up to that point. And when they stratified out for different examples and different things, they found that the Spiro group was significantly more likely to seek breast augmentation than every other group. There is a theory that spironolactone causes premature nipple plate fusion, meaning that basically the breasts are not able to achieve the full size they would have otherwise because you have cooked them with Spiro early on in development. So
I will say, by the way, and I'll reiterate this, I appreciate when people support me on Twitch. I am beginning the process of offboarding from Twitch because they have, like, in order for me to be an affiliate with them, I would have to stream exclusively with them. I'd have to have an exclusivity contract. And I don't want to do that because it inhibits growth. So if you want to support me, then a great way to be able to do that is through direct donations or through my Patreon. So yeah, that's the only show I'll do in case you really do want to support me. But otherwise, thank you. I appreciate it.
Surgery, and I said, okay, I'd rather you not, because I always think of Kanye West's mom, who went in for routine breast augmentation and died. It's not without complications or surgical problems or capsular contracture or other issues. So let's try one more thing. I can screen for breast cancer, but I don't have a crystal ball to say whether my patient reacts to anesthesia and dies under the knife. So that's what we're doing right now. And with that patient, I've had modest growth so far, but I think that they may be a person who was fused prematurely with spironolactone. So I get testosterone levels on people with the intent of erectile function. If you don't want it, and most of my transgender women do not, they say, no, 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 make it go away. I don't want to get morning erections. I don't want anything. Like, they hate it. They call it the dysphoria worm. I mean, there's the, what is the other one that I always say? Oh, God, I'm trying to remember now. The sadness noodle. I mean, there's just like, there's so many funny things that my patients have said to me before that I like try to store in my head. But regardless, if they don't want it to function, I keep it about 15, which is the adrenal levels that are produced when you shut somebody down using the Powers method, which we're going to talk about. If they want it higher than that, I keep them around 50. Anecdotally, African-American trans women want erectile function. Whites don't. I don't know why that is. It's just a thing culturally that I have noted overwhelmingly to be true in a fact of like 90-10. When it comes to white transgender women, they're usually like, meh. Like they're either apathetic or they don't want it. Very rarely are like, it needs to keep working. Whereas with my African-American trans women, almost every single one of them would like to preserve their erectile function. It's like critically important. I don't know if it's a cultural difference or what, but it's something that I'm aware of and I cater to by helping them do this depending on what testosterone I keep them pegged at. All right. So there are other blockers that I don't use because they're terrible. 5-alpha reductase inhibitors. So there's a brand new drug out right now that is injectable, and it treats postpartum depression. So women that are like severely depressed, right? The problem with this drug is it has to be infused, and it has to be infused slowly over a 48-hour period. So you have to be in the hospital with the severe depression, and then they hook you up to it and they infuse it into you. And it's allopregnenolone, which is a neurocorticosteroid that is involved in depression. We find that it is heavily depleted in women with postpartum depression. Giving it to them makes them feel better. Do you know what else depletes neuroalloprogenolone? 5-alpha reductase inhibitors. It blocks the synthesis of it. I wonder why there's such severe depression associated with the usage of finasteride. But yet we hand it out like candy. Just like, oh, you have some hair problems? Here, have some finasteride. Oh, you got prostate cancer? Finasteride.
This is interesting because I have a friend who's on finasteride. And she is a sad person. So I may reach out to her if she will answer my calls. She usually doesn't. But it is interesting.
Meanwhile, these people are severely depressed because we're literally depleting a neurocorticoid, which is super important to their general functioning. I don't write these, like almost never. And when I do, I write them topically, and that's it. I have a compounded finasteride or dutasteride with minoxidil at 10% that I put on the head, but I won't use them orally on people because there's just no reason to do it. The other reason it's stupid is that the overwhelming majority of transgender women have a very low testosterone to begin with. 5-alpha reductase inhibitors don't block testosterone at all. All they do is prevent the conversion of testosterone to dihydrotestosterone, 3 times stronger testosterone. It's a more potent form. So if your total testosterone is 10, why do you have the patient on finasteride? You cannot imagine how often I have people come to me that have a testosterone of 0, 10, 15 that are on finasteride and this and that. And I'm like, what is your doctor doing? Because you just expose them to the side effects for no reason. So don't do that. Dutasteride can also be used topically, like I talked about. I have a compound that does that. Never prescribe any of these things to somebody who basically has a low T, because you're giving them side effects for no reason. So there was a drug called flutamide. There still is, actually, and it is an incredibly potent androgen receptor inhibitor. The best way to describe how it works, and I love this drug class, is here's a testosterone receptor. Spiro, all these other things block or reduce T levels, but flutamide, bicalutamide, and enzalutamide do this. They're like a bowl that sits over top of the receptor. They prevent the binding of the ligand. So it just sits here and inhibits the ability for testosterone to do anything. About 50 milligrams a day of bicalutamide is enough to inhibit about 400 nanograms per deciliter. So pretty solid amount of T you can just wipe out by using bicalutamide. Now, the reason I use bicalutamide instead of flutamide is that flutamide has a horrible reputation. It is like the angry, mean cousin of bicalutamide that causes liver failure. Bicalutamide causes hepatic irritation in about 1 in 500 people. I've seen it once, ever, and it was very mild. We're talking like their AST and ALT went to like 60 compared to the other things they're on. I generally also use bicalutamide for another really cool reason. If I took it, say I had prostate cancer and I take it, no estrogen, no nothing, just bicalutamide, I'll grow breasts. It causes gynecomastia. The reason it does this is that when you inhibit the binding of testosterone, the body recognizes that it's not getting sex hormone signaling, and so it upregulates the expression of the estrogen receptor on the cell surface membrane, thereby sensitizing the cell to estrogen. Why are we giving people a testosterone poison that literally causes visceral adiposity and makes them feel like crap when this exists? It's because people are afraid. They're afraid of this drug, but I'm not, and I write it constantly. You can get it for like $16 a month at Kroger with a GoodRx coupon. I only use this drug temporarily right at the start of hormone therapy until I'm able to achieve what I call capture. Capture is the point when I own your endocrine system. It does what I tell it. It basically has stopped doing what it wants to do on its own, and it does what I tell it to do. And I'll explain to you how I do that in a little bit. I have to edit the slide. I've never seen a hepatic transaminase elevation once. 2 weeks ago, I actually saw it for the first time. Like I said, AST and ALT went to 60.
There's no evidence for what he just suggested. I'm not listening as closely to this part of it because it's talking about like the effects of specific medications. And that's not so much what I'm interested in here. Although it is definitely like a relevant discussion. Yeah, for real. But yeah, I'm not paying as close attention. No, you're fine. Just because like this part is not as relevant. It's cool when he talks about like the basis for why trans people are the way that they are. Like that can be interesting. But to the effectiveness of like certain medications over others is not something that is relevant to my research so much. I'd rather leave that to medical professionals. Like it can become a cultural discussion, but it's much less of one. Or at least it's less relevant to me, I should say. But yeah, I mean, like, it's good to recognize if he is citing something which is inaccurate.
All right, so in not the United States, there is cyperterone, Megace exists here, we have megestrol, but cyperterone acetate, CPA, is a blocker that's used in Europe constantly. It's what everybody uses in Europe. It causes prolactinomas and meningiomas. I don't use it because I can't, but even if I could, I still wouldn't. But you need to be aware of it, because if somebody comes in having taken it and they have, their peripheral field loss or whatever, you need to be aware that literally this thing can cause a brain tumor. I once saw a patient abusing cimetidine. Apparently cimetidine can cause gynecomastia, probably via its P450 inhibition. It screws with the cytochrome P450 system a lot, and so subsequently people try and take it to get gynecomastia, along with a thing called Pueraria mirifica, which is a plant that's like one of the most powerful phytoestrogens you can get that isn't outright estrogen without a prescription. I have a lot of people who are ex-DIY, meaning they used to do this on their own from the street, ordering it from all-day chemists in India and getting it shipped to them, and now they've come legit. They come to see me because I offer the opportunity to informed consent. All right, progesterone. Everybody thinks I'm nuts, that progesterone doesn't do anything. They are wrong. It does. It wouldn't exist in the human body if it had no purpose. If you don't give your transgender women progesterone, they get pointy boobs. I literally jokingly refer to it as trans-cone boob syndrome. They are pointy. They literally look like Madonna. They don't turn out right. It's a cone on a cone, and it looks literally like the secondary nipple, the areola is enlarged, sitting on top of a strange cone-shaped breast, because they never progress past 10 or 4. They are stuck in 10 or 4, and unless you give them this, they will not make it to 5. I have not seen patients make it other than this with progesterone. However, if you look up any other resource, well, not any other resource, but most other resources will say that I am wrong. However, I also do not write this. Ever. Ever. The fact that Yaz and Yasmin are still in the market with drospirenone in them blows my mind. Why? You guys know Yaz, right? I mean, it's a birth control that's like the most sued and litigious birth control to ever exist. Drospirenone is 8 times more deadly than every other progestin out there, yet we still prescribe it to people. Why? There's no need. I don't have to do this because I have this. This is bioidentical progesterone. Now, what I do that's a little different, and it is basically the crux of the method for me, is that I use rectal. And you have to think about the level of compliance I have for my patients, that I convince them to use a rectal suppository every single night of their life. And they do it. The reason I do it is because when you take this orally, about 95% of it is obliterated in the liver. It just never makes it. And their serum levels suck. But when you use it rectally, you wet it in your mouth or into the sink, and whoop, up it goes, and you go to bed. The cool part is progesterone, when absorbed in this way, is a GABA agonist, so it makes people sleepy. So they sleep super well on it. They say it's the best sleep they've had in their whole life. Then, the other benefit is that the distal third of the rectum, unlike the entire rest of the gastrointestinal tract, drains to the portal circulation. I'm sorry, not to the portal circulation, to systemic circulation. Everything else goes to portal, meaning goes to the liver first, but the distal third goes out to systemic. So when you put this in the distal third of the rectum, the capsule will basically start to melt, break down, and then release. And because it's an oil, it doesn't get all sucked up instantaneously. Over the next 24 hours, it is gradually absorbed. Then what's really neat about it, I think I have to go to a further slide to get to it, but I'm just going to tell you now. I discovered based on lab results I had in a patient, and I tried to find a comparative example, and there's a 1998 study on sheep where they inject them with progesterone and they measure their LH and FSH and it goes to 0. So I said, I bet if I can get progesterone levels high enough, I can do a thing like Lupron. Because progesterone is actually a GnRH agonist. Now, if you don't remember how the hypothalamic pituitary axis works, GnRH agonists stimulate the pituitary continuously. As in, like basically they press the button and hold it down. And once you do this, you get a...
Oh god, okay, I get it. I found the autogynephilia takes cringy, but either way, this is a casual stream. In general, with any form of HRT, you should avoid DIY when possible. Some people do it because they can't otherwise. It sucks, it really does. But where you can, for the love of God, talk to a psychiatrist, listen to them, be careful. Yeah. Again, I'm not immediately signing on to all of this guy's takes, right? Because it sounds like there's been a lot of updates and discussions on his opinions. So we're probably going to be looking more into it. Hey, what's up? He was going to try and publish a study for peer review, but a fire destroyed his research and he had to start over with the compiling. Aw, damn. And the part where he went on to make up definitions and claim people who don't require medical treatment weren't transgenders was not great. Oh, wow. Wait, or weren't transgender was not great. Yeah, that's not great. He's just not well informed on the community. That's what it's sounding like. It sounds like someone who practices the medicine but is not informed on like the goings on within the community, and so can't really weigh in with that context. Yeah, that's not great. Yeah, that's not great. So this part's not great, but I mean, like, I get his point. I don't know. Thank you. I feel like I look like crap, but I appreciate that people think I look cozy. I mean, it's hard when you are a practicing physician who is currently doing this line of work, who wants to talk about what they have experienced in the course of their professional work, but it hasn't been peer reviewed. Because, I mean, I want to be consistent, right? We would take, like, if someone who, like, if Abigail Schreier did this kind of shit and she does this, and she does, like, egregious shit all the time, right? Then we would say that she is, like, faulted by virtue of the fact that she doesn't actually peer review any of her work. Cozy Riley, Lo-Fi Hip Hop Society. Yeah. So there is, like, we do have to make sure that we're holding people accountable. The way, and maybe this will help you because this is the way that I'm navigating listening to this video. I am listening to this video looking for specific information to help me with arguments that I am currently making. After we listen to this, as a preliminary matter, I'm probably going to, like, after my finals are done, go through this on stream and also through, like, his updated views to see where he cites to some of the claims and arguments that he makes, and to read those to the extent that they are peer-reviewed and supported by academic consensus, right? So I'm not trying to take this all as, like, an ascription of what is true or false. Oh, interesting. But rather, like, I'm trying to take this more to be like, all right, I'm listening to this. What information might I be able to get from the video if we did a more deep dive into it? That's essentially the way I'm looking at it. You can do what you want with it. I'm not but just from what everyone is saying right now, I'm taking everything with a grain of salt. But that's just me.
A release of LH and FSH, and then it stops. In order for it to work normally, you have to press in a pulsatile fashion, and that's how the pituitary regulates hormones. So if you give them progesterone this way, which acts as a GnRH agonist and is a constant stimulus, LH and FSH fall to 0. When your pituitary is no longer secreting LH and FSH, and they are 0, there is no signal to your testicles to make testosterone. They go off, just off. I never have a patient now that I have to give any other blockers to or do an orchiectomy on. In fact, what's really cool is their testosterone.
That could be possible. I mean, I don't know how big my reach is. I was talking to someone in one of my classes earlier, and they said apparently I'm an internet celebrity, so I don't know. if it would be possible, then sure. I mean, that could be a really cool conversation, I think. But as far as I'm aware, I don't know. I don't know how big my pull is. I aspire to be able to pull off a messy ponytail like that. Whenever I put my hair up, I look like I'm about to grab my musket and fight for the redcoats. I'm not sure if I look cozy right now or whatever, but I'm glad that you like it. And yeah. It sounds weird to have a classmate call you an internet celebrity. Yeah. And I tried to like divert the conversation away from that because it was awkward. And like, I mean, I don't know what you want me to say, right? It's not like I hold myself out to be like an important person. I do this because I enjoy it. And yeah, who knows? You might get as popular as Xander Hall. Oh, yes, we shall see. What I would ever give for that. Nothing, no shade against Xan. He's a good kid. Yeah. I don't know. Well, I'm always thinking about what I'm going to be doing. I think that we're going to have a lot of content go up next week. Since most of my finals will be done, and that will be nice. I'm talking with Occam about, and I don't know. I'm just trying to. There's a lot going on with my life right now, but we'll get back on the schedule. So don't worry. The channel will grow pretty steadily in the future, or at least I'm confident in that. Anyway, I have to go in a bit. So I have to go at 4 because I have a meeting then. So let's listen to a bit more and then I'll head off. All right?
Testosterone falls to usually about 10 to 20, which is the amount synthesized from the adrenal glands. I know that it is because their LH and FSH are undetectable and their testicles are like totally atrophied away. So this is how it's working. That is the crux of how I do hormones differently, is this usage of rectal progesterone. I have also used topical progesterone on alternating breasts, and every now and again I have somebody, and even one cis woman I did it to, who had an asymmetrical breast, and I used it to enlarge the smaller breast and like even them out. And it actually worked, and they got gains, and they were very happy, and then we stopped the drug, and it kind of was like, and it went back, but not as bad as it was before it started. So the presence of the progesterone effectively evens them out, because topically the concentration they're getting is vastly higher than the systemic absorption. I'm sure the other breast is touching some of that progesterone, but when it's right on top of the right side, it evened out the other breast, which was kind of neat. Her period was a mess though, but she didn't care because it was that or surgery. She was like, I'm getting this fixed. So it was one of those things, kind of like my other patient talked about, where it's, a risk-benefit ratio, but rather than going under the knife, they opted to do that. WPATH, progestins, with the exception of cyproterone, the inclusion of progestins in feminizing hormone therapy is controversial. Back in 2000, you see all these citations are always going to be like 80s, 90s, because this is WPATH. Like they don't update their stuff. Because progestins play a role in mammary development on a cellular level, some clinicians believe these agents are necessary for a full breast development. However, clinical comparison of feminization regimens with and without progestins, mind you what this says here, progestins, not bioidentical progesterone. It says progestins. Found the addition of progestins neither enhanced breast growth nor lowered serum levels of free testosterone, which I just told you is absolutely not.
Fuck. What? All right, hold on. What did Blair post? I swear to God. All right.
All right, folks. Thanks for installing vidIQ.
Sorry. It always does that. All right. I'm so tired of her. Well, back to the grift. I mean, like, this is not surprising. Yeah, I'm sorry. Not surprising in the slightest. What do you want from me, fam? I mean, like, you realize what both of these are, right? It's just like anecdotal evidence to try and scaremonger and make and like both of these actually have like the same logical fallacy of like trying to isolate. Like I can tell you exactly what the entire videos are from here. We'll talk about them. I'm actually going to be doing deep dives into like both of these subjects in the upcoming weeks. But basically, TLDR, overwhelmingly evidence shows that like gender affirming care for trans youth is fine because like you put them on hormone blockers until they're of such an age where they can make an informed decision about whether or not to go on HRT fully. And then with predators, yeah, like, or wait, hold on, Zoe Laverne. So hold on, is this like a trans woman? I don't know if this is actually a trans woman. I read it like it was a trans woman, or if it is, then it's the same. Like if it's not, then it's the same kind of. It's the same kind of logical fallacy, right? It's like, oh, well, here's someone from X minority or X group who did something terrible. I guess that means it's possible for someone from that group to do something terrible, which is like, yeah, no shit. But usually, like, the argument that they'll make is like, try to imply some kind of quality about that group at large to mean that, like, oh, by virtue of having the quality of belonging to this group or whatever qualities entail belonging to that group, that makes it more likely that you would do X, Y, or Z, right? So I don't know if this is a trans predator, or maybe it's just women in general. But yeah, here I'll put this on my skip it. I'll put it on the content fodder. We'll get around to it. Yeah, in a couple weeks I'm going to be doing a deep dive into like trans youth, so we'll react to it then. All right, cool. Oh hey, it's 4 minutes until the meeting I'm supposed to go to. All right. Well, that's it for now. I'll stream again later today because my schedule is completely fucked, as well as my life. What do you want from me? All right. Where do you want me to send y'all? I'm not going to do an outro. All right. There's 26 of you in Twitch. I'm going to send you off to... Who's someone I can send you off to? Who am I following that's live right now? The Surfs. The Surfs is starting. I'm sending you off to the Surfs. All right. Wonderful. Or is the Surfs going? I actually don't know. Apparently, it's not letting me. At least we avoid the next TSO or TOS moment. Yeah. No, that was fine at least. I can't find anyone small to raid into. I actually can't. I'll raid you into Kevin Logan. Yeah. KF Logan. Yeah, here we go. All right, I'll raid you into Kevin Logan. All right, talk to y'all later. All right, peace. In so many seconds. And send you